to joining us again this year at the Sydney Neonatal Lectures. This year, I've been handing over the baton to chair sessions and organize speakers, but of course, anybody can be recommended to us about speakers which we would like to hear and bring topics in general neonatology, and specific sort of details. I'm, of course, my interest is hemodynamics, so I'm starting off this month with some hemodynamic talks. And today we got Professor Amish Jain from the University of Toronto and as a clinical worker in Mount Sinai. And his interest is the same as neonatal hemodynamics, and he's I think the founder of the Neonatal Hemodynamic Research Center. If you don't know it, look it up on the YouTube. They have beautiful presentations there again about this particular topic. And I asked him today because I know his body of work is about blood pressure and what the clinical relevance is and the physiology sort of behind it. So Amish, the floor is yours. Please share your screen.
I would. Thank you so much, Kurt. Okay.
Yep.
There you go.
All good.
Awesome. So sort of thank you everyone for giving me a chance to give this talk. And as Kurt mentioned, we are going to talk today about blood pressure physiology. The topic given is relevance in the NICU. And what I hope to achieve basically is to talk a little bit about the history of how blood pressure in the NICU domain has evolved, and the good and the bad about it, and what we share a little bit of work that we have done to try and understand its physiology and try to understand its relevance in the NICU setting, and then hoping I'm leave you with more questions than answers, to be honest. But hopefully that questions would spur you on to actually think a little bit more about this. So before I start, some funding disclosures. I have received sponsorships from Medical Informatics and Mallinckrodt Pharmaceuticals for website development for a TNE curriculum lectures for the Neonatal Hemodynamic Research Center. As Kurt mentioned, if you haven't, please go ahead, check it out. It's on YouTube, and we also have our own website called neonatalhemodynamics.com. And there's a lot of freely available lectures given by experts. So let's start with this, and I'm not
recording
sure
in progress
whether everybody has seen this, but most people must have come across some iteration of this. That a long time ago, this is 1992, the British Perinatal Association meeting, a group of a handful of perinatologists came together, and at that time wrote a consensus article about the lack of data on management of blood pressure in preterm infants. And basically just came up with this, that you can see here, for this study, the normal range of blood pressure is in very premature infants are needed. But at the present time, the working group agrees that a mean arterial blood pressure equivalent to gestational age in weeks is adequate as a minimum value. And then they go on to talk about how to treat the blood pressure with colloids. And again, people have forgotten about this, but what they meant was colloid or blood if there's a possibility of hypovolemia, and then talk about dopamine and all. So this essentially mean blood pressure as equal to gestational age was nothing more than 5 people getting together and thinking that in the given 1992 lack of data, it seems to be okay. And that has somehow stuck. And I guess it's stuck because of the simplicity of it. About 10 years ago, this was a review article published in Archives, which sort of outlined what was proposed as a standard management of hypotension in very low birth for an infant. It doesn't talk about anything why the hypertension is from. It just talks about hypotension management. And as you can see, and I'm reasonably sure many of you have actually seen or practiced that, it talks about 10 to 20 mils of volume, followed by dopamine of 5 to 20, followed by dopamine, still not working out, then noradrenaline, and still not working out, then possibility of steroid. And that flowchart of management of hypertension remained consistent. for many, many years, we practiced that. Honestly, I was trained in UK in 2004. I started my training there. I used that for 2-3 years myself. And we never thought about who the patient is, what the blood pressure is from. We always followed this rigid algorithm for all hypertensions, irrespective of etiology. So is hypertension important? There were many, many papers in the past that it is, but what about today's? So it's a very interesting pair of articles published in same journal, Archives. So if you look at this article from 2015, these guys looked at almost 5,000 babies, and they used the minimum mean arterial pressure in the first 24 hours, calling min-map 24. So they recorded that for 5,000 babies and then did a regression analysis to try to understand whether it's associated. And what they found was that the minimum mean arterial pressure or mean blood pressure in the first 24 hours was an independent risk factor for IVH, BPD, and mortality, essentially saying that hypertension during the first 24 hours of life is associated with adverse outcome, even now, which we already knew about. So just confirm that it still is. But what's interesting is that exactly a year later, another study, which was a prospective observational study, which looked at 23 weekers, 26 weekers, and actually recorded hourly BP values and the management, the treatment, the antihypertension therapy. And they did a regression analysis for death or neurodevelopment disability. And what they found was a high risk of death or neurodevelopment disabilities associated with therapy, even after they adjust for pre-therapeutic blood pressures and not neurodevelopment alone. So basically mortality was high. So what they found was that independent of early blood pressure changes, therapy itself is associated with increased risk of death or disability when controlling for risk factors. So it's interesting that the disease is associated with adverse outcome and the treatment as well. So where does it leave us? Like, what do we do? Do we treat? Do we not treat? Now, what's interesting is that 92% of patients in this study were actually treated by exactly that algorithm, bolus followed by dopamine. That was their policy. So one thing we can safely say that this approach doesn't really work. Treating hypertension as a disease itself, rather than a symptom of a disease, and managing all hypertension the same regimental way does not lead to better outcomes. And we have tried to examine that over and over again. This was a systematic review by Gene Dempsey and Keith Barrington, 2007, quite long ago, same time when we were talking about these studies. And they could not find a definite threshold in literature that is associated with adverse outcome or any intervention that improves or at least undo that adverse outcome. And obviously they recognize there's a lack of prospective research in this issue, but they also suggested that it is possible that a simple blood pressure threshold that indicate need for therapy does not exist. Now, this was 2007. It's 15 years later. We still don't have a prospective research on this topic, and we still don't have a threshold that we can absolutely say requires treatment, and we still don't know what to treat with from a RCT perspective, at least. So this type of lack of data have led to this, and I'm not sure whether it's actually common in Australia to call this, but when I came to Toronto and I know it was used to be common thing, people will say that baby has a numerical hypotension. I'm not entirely sure what that meant. So I asked, it seems to mean to people that hypotension, which is just a number, doesn't really have a relevance. And it's just a numerical hypertension which has no relevance, and hence the risk of hypertension or the risk of treatment outweighs the benefit of it. But how do we decide that? Who has numerical hypertension and who doesn't? It's a hard one. And I personally have seen it getting it wrong on numerous occasions. So before we go any further, let's talk a little bit about physiology. What is our clinical goal? And I'm sure everybody will agree. Our clinical goal really is to optimize or correct oxygen delivery, or cellular metabolism, to improve or preserve organ performance. That's all we care about. We want to ensure organ performance and we want to optimize patient outcome. Now, at the organ level, as you, I'm sure, know, it's a balance between oxygen delivery and oxygen consumption. Now, the scale is showing equal. It's not usually equal. The body works in surplus, which means the delivery quite commonly outweighs the consumption. Doesn't completely balance it. But if we can measure delivery and consumption, we'll be okay, because we can tell what's going on, which could be done by mixed venous oxygen saturations. Unfortunately, in our practice, we don't really have access to that. But if we did, we could easily measure somebody's mixed venous oxygen saturation and arterial oxygen saturation. Arterial should be 95, mixed venous 60 to 80%. We can tell whether the baby is extracting adequate oxygen or too much extraction, which will indicate lower delivery, or too little extraction, which will indicate cell death. Unfortunately, we can't. So what we can focus on really as a clinicians is oxygen delivery. So we have to understand that DaO2, which is oxygen delivery, is nothing but a product of cardiac output and the content of oxygen in the blood. The content of oxygen is a product of hemoglobin and arterial saturation. So there are three key variables that we as clinicians can think about when we're talking about oxygen delivery: cardiac output, hemoglobin, and saturations, right? Those three are modifiable factors which will allow us to optimize delivery. Now, cardiac output, as everybody hopefully knows, is nothing but a product of stroke volume and heart rate. So in this context, tachycardia, a bit of tachycardia is not a bad thing. It increases cardiac output if the stroke volume remains the same, provided it's not too high, in which case it will reduce stroke volume because of poor filling. So it's important to know that cardiac output is stroke volume and heart rate. What about stroke volume? What determines that? Now, the stroke volume which is the volume of blood coming out of the left ventricle or the right ventricle at each beat. It depends upon three things. Preload. So preload is the volume of blood in the ventricle at end diastole. Preload is not the same as venous return or systemic venous resistance. But by length tension relationship or flying Starling law, higher the preload, higher the stroke volume will be, up to a point beyond which it will not increase anymore. So you can increase stroke volume by increasing preload. Afterload has an inverse relationship. If you increase the afterload too much or it's high, the stroke volume may go down. And then the myocardial contractility inherently will increase stroke volume. The net stroke volume in a living person is basically an interplay of preload, afterload, and contractility at any given time point. So you got to think about that. You got to think about stroke volume. You got to think about what's the preload like, what's the afterload like, and what's the contractility like, and what can I increase or what can I decrease, and where it's coming from. Okay. So why we talk about blood pressure? Well, think about it. What else can we talk about in an ICU? What else do we have? The other markers of adequate systemic perfusion include heart rate. Are we going to rely on heart rate? Not necessarily. Cap refill time, yes. When it's really bad, it's prolonged, it probably means something. So it's specific, but it's not sensitive. And we all know that many patients with severe shock type features don't really have a cap refill time which is long. So it takes time to get prolonged. Base deficit, lactate, urea, creatinine, urine output. These are markers of perfusion. None of them are perfect. They all mean something. And now we are using NIRS a lot more. And the near infrared spectroscopy in the brain or in the renal or splanchnic. Again, it's a piece of the puzzle, but it's not absolute. So our field is such that we have to do a holistic assessment. And in the context of all the markers we have, blood pressure still remains reasonably important to ensure it doesn't tell the story. And hopefully that's what I'll show you. So we talked about that blood pressure is, what is blood pressure? If you look at the calculation, it's systemic vascular resistance multiplied by cardiac output, right? Now, we talked about the cardiac output. and the SVR. But the blood pressure is not just blood pressure, has three components. The systolic blood pressure is essentially a force exerted against the blood vessel wall when the aortic valve is open. Now that pressure varies directly, although not completely attached to it, but does varies with the cardiac output. So in theory, or in a sense, systolic blood pressure is thought to be a measure of amount of cardiac output. Again, I'm going to say again, it's not absolute, but for the most part in the critical care setting at least. The diastolic blood pressure is a resting force of the blood against the vessel walls when the aortic valve is closed, and hence it is more reflective of the size and number of blood of the vessels. So essentially a systemic vascular resistance. So systolic BP is thought to be more reflective of cardiac output, and diastolic BP is more reflective of SVR. While mean blood pressure, for the most part, especially if you're measuring non-invasively, is a calculated value by this well-known formula. And as you can see, the diastolic blood pressure contribute twice systolic. So if you have low diastolic, the mean goes lower for more. And if you have low systolic, the mean doesn't get affected that much. So it's something to keep in mind. So we examine this phenomena or this theory that some time ago by using almost 1,000 by using more than 1,000 paired value of left ventricular output and blood pressures in almost 500 babies. So essentially, whenever we do an echo in our center, we record their blood pressure at the time, and we also calculate their LVOs, so left ventricular output. So we use that as a marker of systemic blood flow and ask the questions: does the LVO in preterm babies reflective of blood pressure, or which blood pressure? And this is what we found. Then among all the markers that could affect LVO, gestational age was associated with the left ventricular output. But among the blood pressure, it was the systolic blood pressure, which was independently directly associated with left ventricular output, but not diastolic and mean. Right? When we looked at correlation analysis, we found the same thing, that in various subgroups of patients, it was the systolic blood pressure which correlated with LVO. But when we looked at pulse pressure, which was the difference between systolic and diastolic, that had give us the highest correlation coefficient. But if you look at it overall, they're all quite poor. So essentially, they're all correlated poorly, but within those pressures, pulse pressure gave us the maximum correlation, followed by systolic. But the mean diastolic didn't really do anything. When we asked the question, which blood pressure discriminated patient with low LVO or LVO less than 150, we found that systolic BP had an area under the curve of 0.70 with a threshold of 55 mmHg. But the pulse pressure less than 23 mmHg gave us an area under the curve of 0.75, saying that among the BP that we had, if you want to diagnose patients with low cardiac output, then pulse pressure probably is your best bet, followed by systolic, and not mean and diastolic. However, overall, the correlation and their ability to diagnose patients with problems was quite poor. So let's look at a little bit about the different types of shock and what BP can happen. So in our practice, the first three shocks are probably more common than the fourth one. We know this is going back to mid school. So hypovolemic shock. In hypovolemic shock, you've lost a lot of volume, so your main problem is preload. That's your predominant problem. So the cardiac output is usually low, can be maintained just about it. Occasionally, people have said it could be even higher because of exaggerated compensation mechanism, but usually is normal or low. But the SVR in this patient usually is on the higher end because they get vasoconstricted to try and maintain, to compensate for preload. And because of that, the mean BP may be same or a bit low. Then distributive shock, which is sepsis or neurogenic shock, which probably is the second most common shock that we see in NICU, or the most common shock. The main problem is low SVR. The preload can be low or can actually be normal, right? The cardiac output can be within normal range or high. Occasionally, when it is decompensated, can be low, but mostly it's high. And here the main problem is low diastolic BP. Mean could be maintained, or because the mean comes more affected by diastolic BP, could be low. And then cardiogenic shock is low cardiac output primarily. And because of low cardiac output, you get a very high SPR, and the preload is high. The LV is or the ventricles are dilated in this setting, and the diastolic BP usually is on the higher end. And systolic is low, but the mean could be in the normal range. Now, why is that important? It's important because when you're looking at the blood pressure and shock, you got to think about what is the relationship, which type of shock am I looking at, what the blood pressure might do, because not all blood pressure will be low for all shocks. And why is that? And you can see here, this is a schematic of short-term control of blood pressure in our body. So when our blood pressure falls, the baroreceptors, which are in the ascending aorta and the carotid sinus, actually sense lower pressure coming in it. And because of that, they send the signal to the brainstem, and the brainstem, in a compensatory mechanism, send the signal back to the periphery for vasoconstriction and to the heart to increase both heart rate and stroke volume so that they can compensate. And that compensation will increase the blood pressure again, and so on and so forth. So this is a normal adaptive mechanism, and we use it in clinical practice all the time. The baby's tachycardic, must be compensating for vasodilatation. We don't connect the dots all the time, but that's what we are trying to basically say. That there was a transient time of low cardiac output because of vasodilatation, to which the brainstem responded, made the baby tachycardic, increased stroke output for hypercontractility and vasoconstriction to maintain blood pressure. Works for a short term, as a short-term measure. But then there is also two types of septic shock that we all know about, the cold shock and the warm shock. The warm shock is the classical shock we talk about, where there is vasodilated, normal or brisk capillary fill time, hypertension, low SPR, normal or high LV function, tachycardia, increase or normal LVO, and so on and so forth. And that occurs because of the predominant inflammatory mediators causing vasodilatation. On the other hand, the alternate shock is the cold shock, where in response to a septic process, the patient has this massive catecholamine surge. And because they have a catecholamine surge, it's not a compensatory mechanism, it's the primary problem. And it causes tachycardia because of adrenaline surge, but at the same time cause vasoconstriction because of norepinephrine surge and all the other catecholamines, which will cause tachycardia, poor perfusion. Blood pressure can be normal or mostly high, and you can develop LV dysfunction and low cardiac output, but the blood pressure can really be high. So it's bestowed upon us to actually distinct the two. And in my experience, the extreme preterm, and I'm sure Kurt will agree because he published papers on that, usually present with warm shock. Even the few that I've seen present with cold shock very quickly go into warm shock. But the term kids, the late preterm, could present with cold shock and stay in cold shock for a period of time. So it's something for us to distinguish from a compensatory mechanism versus a primary problem of cold shock itself. So let's talk a little bit about clinical context, because that's important. What about transitional hypertension? So first, by far the majority of work till date in preterm infants and hypertension has been done in this context. Starting from a long time ago, almost 15 years ago, when Alan Groves, a good friend of ours, actually published this paper with John Skinner, where they examined blood pressure and the flows using echocardiography in 4 different vessels, and essentially found virtually no correlation between flows in these vessels and the blood pressure components, except for this one correlation at 6 hours of age or 5 hours of age between SVC flow and mean BP. And this inverse relationship, higher the mean BP, lower the SVC flow, had a reasonably poor correlation, but it was statistically significant. And these guys concluded that in sick preterm infants, low BP does not correlate with poor perfusion in the first 48 hours. However, it may be that high systemic resistance gives you high mean BP, but lower SVC flow just in the first few hours of life. So the correlation was not great. Then very next year, these guys published an observational study of 22 ELBW infants who had hypertension, and they divided their cohort into severe hypertension and mild hypertension and measured their endogenous catecholamine levels. Now, in our body, we have dopamine, which is produced, and dopamine worked in two different ways. It can work directly on the alpha receptor itself or the dopaminergic receptors, or in the fat cells, in the fat tissue, it actually gets converted into norepinephrine to work on alpha receptors. So by measuring the dopamine levels and norepinephrine to dopamine ratio, you can make an estimate of how much dopamine is getting converted. And what these guys found was that the babies who had severe hypertension had higher circulating dopamine levels and lower norepinephrine dopamine ratio, which means that their ability to convert dopamine to norepinephrine in the fat tissue was reduced, which is why they were hypertensive. They were sort of trying to come up with a mechanism. Now, giving dopamine to patients who have high dopamine levels already may not be the best thing to do. But that was their idea. That's what they came up with. Physiological study, really. So we asked the same question. I say, you know what? When we have transitional hypertension, what is the underlying physiology? Now, for that, you have to first define what is transitional hypertension. Is any hypertension in the first 3 days a transitional hypertension? Like a baby who's born with GBS sepsis in his blood and his low blood pressure on day one, is that transitional hypertension? We didn't think so. So we think the transitional hypertension should be a term completely restricted to patients who have no other etiology but prematurity and transition. So we came up with the definition that patients who had a mean blood pressure below gestational age for more than 1 hour within the first 24 hours, but were otherwise well. They were FiO2 were less than 40% and they had no sepsis. So we called them transitional, and we did a match case control study from using our Echo database, where we used a prospective cohort of study that one of our colleagues, Dr. Deshpande, actually recruited, and we used that prospective cohort to be the controls, and then we found the cases. And you can see we had 14 cases, 27 controls, because we matched them 1:2, and they were similar because we matched them, except their blood pressure were low. And here you can see here the hypertensive kids had a very low, much lower blood pressure than the normotensive kids. And the mean gestational age was about 25 weeks in both groups. And when we compared their echocardiographic finding, what we found was that the hypotensive neonates actually had higher left ventricular function, not lower. Their shortening fraction, ejection fraction, their mean velocity, circumferential fiber shortening, everything was increased. So they had higher systolic performance, but they had lower systemic vascular resistance, and which probably why their systolic performance was high. And so was their cardiac output, was similar in both groups. There was no difference. But why was their systemic vascular resistance low? And we found the only difference between the two groups was a large PDA in the hypotensive group, which would give you a low SVR. So the hypertensive group were more likely to have a large PDA, unrestrictive, with more predominantly left to right shunt. We basically thought that transitional hypertension, otherwise well infants, is primarily a function of PDA remaining open, who transiently give you the hypertension because of low systemic vascular resistance. It is not a problem of vasodilatation, and it is not a problem of cardiac output or cardiac dysfunction. So patient with PDA, should they be given dopamine or dobutamine? Or should that have an effect? Or worst, actually boluses of fluid. They are not hypovolemic at all. So that increased, that sort of raised the question that is our management truly physiological? And are we that surprised that our management hasn't worked out yet? So what about the other context that we commonly see hypertension, and that's sepsis or NEC? There was this highly quoted paper from Kurt and Nick from Australia, where they prospectively studied patients with sepsis and did the sequential echocardiography on them. And what they have very nicely noted is that these patients in the beginning have higher cardiac output than what's normative data would be. And those patients who maintain cardiac output high survive, and those who goes down are more likely to die. So there are two things that basically came out. One, that they established the predominant phenotype in the preterm sepsis, late onset sepsis, is of high cardiac output, low SVR. So vasodilatory shock, high cardiac output. And two, the lack of compensation or failing to compensate for a longer period of time or indicates decompensation is reflective of patients who are high risk of mortality from it. To me, the biggest thing was that they confirmed the phenotype, right? So we also asked this question: what is the relevance of blood pressure in late onset sepsis? So what we did was, sorry, what happened to my, yeah. So we basically did a study of 147 patients who had late onset sepsis with organisms other than cons. We established their baseline record of blood pressure, and these are all non-invasive blood pressure because that's what we normally have. So we use that. 24 to 48 hours prior to sepsis, whatever the lowest BP was, we call that baseline. And then post-sepsis onset, defined by collection of blood culture, we recorded their lowest BP in every 12-hour period. And we asked the question, does the blood pressure differ between patients who had organ dysfunction or not? And organ dysfunction defined by this. And you can see here, organ dysfunction are the patients who had the mortality. The babies who did not have any of these features just didn't die. So we wanted to capture a high risk population. So here is a graph. You can see here, baseline blood pressure are very similar. But immediately after, in the first sepsis onset period, the first 10, 12 hours, the plus sign, which is the babies who had organ dysfunction, their BP dropped. And other babies who had no organ dysfunction, the BP remained reasonably stable. And you can see here, this is mean, this is systolic, this is diastolic. So essentially, non-invasive blood pressure itself was able to distinct babies who are going to be diagnosed with organ dysfunction with those definitions and those who don't within the first 12 hours itself. The drop from baseline indicated high-risk patient. When we looked at babies who died versus those who died, we found the same thing. That even within the organ dysfunction, and you can see here, the drop in BP, the delta, was much lower in those who survived and was much higher in those who died. And we looked at absolute BPs, change from baseline and percentage drop, and they all told the same story. And among all the three blood pressures, systolic BP was the best in distinguishing those who are at high risk of death, with an area under the curve of 0.83. And these are the cutoff we came up. And mean BP was not that far away. It was 0.80. Systolic was 0.83. But the mean BP cutoff was 31 mmHg. And that was independent of gestational age or anything else. And absolute BP values performed just as good and actually even better than percentage change. So the bottom line here was that blood pressure do matter in septic shock. They do identify a patient at high risk. And a sequential monitoring early in the period, just when you're starting the sepsis episode, if the blood pressure drops down from baseline, it will identify a patient who are highest risk of developing organ dysfunction and death. If the blood pressure remains really robust for the first 12 hours, those patients have very low chance of dying and very low chance of developing organ dysfunction. Okay, doesn't really mean cause and effect. At the bare minimum, it will pick up high-risk patients. Okay, so when you're talking about blood pressure and its interrogation, you also have to talk about the drugs. So one of the things that we have to do is we have to know our drugs. What do they do? How do they respond to various blood pressure? And I'm not going to go into detail of this, as it's well published, but you can see at the top you have milrinone here, who's an inotrope and a vasodilator. So it will increase the contractility, but will cause vasodilatation in both pulmonary vascular bed and systemic vascular bed. Then you have dopamine, increased contractility, again a vasodilator, but not potent, but a bit of vasodilator because of beta-1 receptors. Epinephrine, if you give it in higher doses, more than 0.1 mics, it's a very potent vasopressor and an inotrope. So you're going to have high PVR, high SVR, inotrope, and all that. But if you give low dose epinephrine, 0.01 to 0.1 mics per kg per minute, you're going to get increased stroke volume and cardiac contractility purely because of beta-2 receptor. But you're going to get a vasodilatation effect. Again, because of beta-1 receptor, because that doesn't affect the alpha receptors. So it's important to know epinephrine is both. Low dose low dose is called the cardiac dose, and slightly higher dose, like more than 0.1 or 0.12, is the alpha dose. Dopamine is primarily alpha-1 beta-1, and it actually increases potent vasoconstriction. Norepinephrine is the same, it's an alpha-1. Sorry. So norepinephrine is also a potent vasopressor, and then you have vasopressin, which actually affects cause vasoconstriction. Now, what about the use of these drugs? And we have virtually no data. The only randomized controlled trial is this 40 baby trial of fluid-resistant shock who were randomized to epinephrine and dopamine. And you can see here, the guys presented their data as less than 31 weeks and more than 31 weeks. And really, 9, 9, 11, 11 patients. So not much you can write home about. But you can look at the preterm here, and you can say, maybe you can say, that epinephrine use was associated with more establishment of hemodynamic stability than dopamine use. But really, you will be pushing yourself. That's the only study we have till date in which is a RCT or actually any quality data on septic shock management. And based on that, we did a retrospective study looking at 156 patients who developed hypertension in our unit in Toronto and received either dopamine or norepinephrine as a primary inotrope. Now, this was driven by the fact that in 2018, we changed practice from dopamine to norepinephrine. So we wanted to compare historical cohort and how they're behaving. And what we found was that we had 43 patients who received norepinephrine as a primary inotrope, and historically had 113 patients who received dopamine as a primary pressor for sepsis-related hypertension. And norepinephrine in our cohort was associated with lower mortality, lower predecessor mortality, lower incidence of new onset NEC or sepsis after, and also lower incidence, lower odds of new diagnosis of IVH. Now, that's all good, but this is not robust evidence because obviously there's a performance bias. Because when we started changing our practice, we also standardized our practice of norepinephrine. And what we also found, but the norepinephrine dose that we were used was 0.05, but typically 0.2, 0.25, which is higher than what dopamine dose people will typically do, which is 5, 10, maximum 15 before they give up. Now, 15 of dopamine is only equivalent to 0.15 of norepinephrine. So it's not really a like-for-like comparison if you're using a higher dose of one drug compared to the other one. So we don't think that was robust enough evidence, but it gives us a signal, and we use that signal and that evidence to actually start a prospective study, which is right now running. We are doing a comparative effectiveness research study across 28 NICUs in Canada, Japan, Ireland, Israel, and the United States. And by the way, if centers in Australia are interested, we will be more than welcome to join it. Essentially, what we are doing is we are comparing dopamine versus norepinephrine as a primary vasopressor in vasodilatory shock physiology when used in standardized way with equivalent doses, and then gonna compare what's their effect on treatment failure and clinical outcomes are. So it will still be a few more years before we have the answer from that, hopefully. The other thing to think about is what are the effect of drugs and other things. Like for dopamine, we know from this animal experiment that in the context of hypoxemia, dopamine will increase PVR more than SVR. So it may affect your PVR-SVR ratio. Just something to keep in mind when you are treating a hypertension in the context of, say, PPHN or pulmonary hypertension syndrome. Norepinephrine and PVR, majority of patients actually have the PVR to SVR ratio either remains same or goes down. There are occasional patients go up. And then what about vasopressin? And this is a study, a cath study from children with pulmonary hypertension who received a bolus of vasopressin pre-post measurement of PVR, SVR. And you can see here, vasopressin, almost all of the 5 kids who got vasopressin actually had a reduction in PVR to SVR ratio because it increased SVR and never touched the pulmonary vascular resistance. So if you're concerned about a kid who's hypotensive, who also had pulmonary hypertension, and you don't want to touch the PVR-SVR ratio, exclusively increase the SVR, perhaps vasopressin is physiologically more appropriate than dopamine, because norepinephrine is a hit and miss. You're not sure what exactly you're going to get. What about role of echocardiography? Now, I find it very helpful in hypertensive kid, particularly in hypertensive kid who are not responding to your first assessment or first management. And why? Well, it gives us a picture of all the aspects of the equation. It gives you a qualitative assessment of preload just by looking at the end diastolic volume of the heart. You know the preload. If the preload is okay, there is no reason to give a bolus. It gives you a qualitative and quantitative assessment of contractility. You can measure stroke volume and cardiac output, but even though you cannot measure SVR, you already know mean blood pressure and you know cardiac output. From that, you can guesstimate. So patients who have normal BP but low cardiac output have to have high SVR or TPR, total peripheral resistance. Patients with very low BP or low BP but normal output or high output have to have low SVR. So that allows you to identify the physiology is vasodilatory or vasoconstrictive in nature based on knowing 2 of the 3 variables through echo. So does it modify clinical decisions? The short answer is it does. From Toronto, we published our data both from sick kids and then from Sinai. When we looked at the number of echocardiography consultation and how many times it led to a change in management, and you can see here, systemic hypertension as an indication, 81% of scans led to a change in management of what people were doing. And that was the highest. And since then, there are 4 more studies of that nature, and they all have shown the same thing, that when you do a functional echo or a TNE in the context of hypotension, it by far most commonly lead to a titration of treatment. But does that matter? A study from our centers recently completed, the manuscript of that is under review right now, but we presented that in PAS, actually show that it does. So we had 680 patients over 10 years who had either inotropes or INO and were critically sick. And half of them were managed by using echo. Other half were managed where clinician did not use echo. So we compared their outcomes, and after adjusting for their illness severity markers, you can see here clearly that the mortality in patients who were managed with echo were lower compared to those who were managed without echo. And so was their death or CLD composite rate. And when we did a subgroup here, patient receiving inotrope, and you can see the mortality was 28.98% in those managed clinically without echo and 16% in those managed with echo. So it clearly helps you, it seems to help you, not clearly helps you, seems to help understand and titrate therapies and may have an effect on treatment. So put it all together, our goal is cellular metabolism. Cellular metabolism depends upon the target organ flow and the oxygen content of that flow. The blood oxygen content, you have to remember, is a measure of oxygen and saturation. So those 2 things have to be fixed. And the flow. The flow is cardiac output, basically, which itself depends upon afterload preload, contractility, and heart rate. Okay. BP that we measure is connected to the cellular metabolism by this equation. SVR time cardiac output. It is a part of the equation, tells you a part of the story. It is not the be all and end all of cellular metabolism, right? So when we are managing these patients, if we can think about any patient who had abnormal cellular metabolism in the context of optimized blood oxygen content, for example, blood transfusions or increase FiO2 to sort out the saturation issues, and think about the patient whom we can optimize preload, inotrope by contractility if required, afterload by giving pressure or vasodilatory or sometimes period treatment. We could get the patient where we want to get without getting blindly fixated on BP alone. Sometimes it does not tell the story, sometimes it does. So basically, we want to consider and balance the pharmacological effects against pathological alterations and undesirable effect. And sometimes high BP needs treatment, and sometimes low BP does not need treatment. But many times, previously normal blood pressure kid drops BP, I can almost guarantee you, almost 100% of time, that blood pressure is significant. So coming back to it, comprehensive assessment of organ perfusion and performance. Thinking about stroke volume, preload, is the patient intravascularly depleted? Is there impaired cardiac filling? Is there reduced pulmonary systemic venous resistance? You have to ask these questions. Is the patient bradycardic, tachycardic? Is it tachycardic a good thing, or is too much reducing inflow, and so on and so forth? I will end by just introducing this new study that just came out. One of the big problems we have in our field is non-invasive blood pressure monitoring. And, at an individual patient level, it can be really crappy. As an overall, it probably helps. But there are oftentimes questions about its accuracy and so on and so forth. And the intra-arterial pressure monitoring is not easy to obtain, especially in shutdown septic kids and preterm kids. So these guys have just developed a new continuous non-invasive blood pressure monitoring in neonates and just published this paper where they demonstrated the feasibility and accuracy. And it's essentially a capitance sensor. They have a band where there's a sensor at the bottom here, then there's a soft band, and on top there's a wireless device which wirelessly transmit the arterial signals to basically an iPad equivalent, which converts that into a system which have already been trained by artificial intelligence into converting the arterial pulse into SBP and diastolic BP and mean BP, and continuously monitor that. These guys have done a study of 81 neonates, and this is their age of study and the gestational age. They got 347,000 data points from 81 babies and compared intra-arterial readings with the readings by the device. And as you can see here, the mean error was not that high. Standard deviation was about 7.9, 6.6, and the correlation was quite good for both systolic BP and mean BP, a little bit lower for diastolic BP, but it did significantly correlate. And based on these data, the device have just achieved FDA clearance, and they are now commercially available in the United States. We in Toronto are in communication with them, hoping to get the device and do some studies to try and understand. Because if it does work, it would really be a very useful thing for us in these patient population. So to end the story, what should we do with BP? Should we disregard it? The short answer is no, absolutely not. But we have to interpret it better. We've got to be smart about it. We've got to think about systolic, diastolic, mean, not just mean. We've got to think about what is the target. Is that target blood pressure or is the target organ perfusion? Blood pressure should alert us toward assessment of more comprehensive assessment of organ perfusion and cerebral blood flow possibly. And then how do we target that? And that requires we define pathophysiology and understand the context. I am far more happy or not happy. But I'm far more settled with a mild transitional hypertension in a well-preterm babies. I can leave that alone without a sweat. But a septic patient who's had normal BP for a long time, had a big drop in blood pressure, even if it has not met the third centile, I feel really uneasy not treating that patient who's developing hypertension. So those type of things have to be thought about before we can decide whether we can treat or manage conservatively or just enhance monitoring. But absolutely, I don't think BP is something which is not relevant. I think it's highly relevant in our patient population or any critical care population. And hopefully we know how to measure it better. So I will leave you guys with this quote. And this is from Albert Einstein. He said that if I only had 1 hour to save the world, I would spend 55 minutes in thinking or defining the problem and only 5 minutes in solution. And I think in an ICU, we oftentimes do the opposite. We just don't spend enough time in thinking about the problem and we want to go to the solution too soon. Blood pressure, to me, or hemodynamics and blood pressure and perfusion perfectly lend yourself to taking your time to think, define what the issue is, and then treat it based on what you found the issue might be. And with that, I'm happy to take any questions.
Thanks, Amish. That was great. There was a beautiful overview about the concepts of blood pressure, and you taught us and showed us physiology and the importance of the aspects and the details of blood pressure, including systolic, diastolic, and pulse pressure. And then you went to your work about the application in clinical practice and what you can see there. And I thought it was a great overview, and with the focus on blood pressure. Please type your questions in. There's one question, and I have some questions as well. The first question is from Thomas, is about distributive shock. And are there situations in newborns where they develop neurogenic shock? And do neonates get anaphylactic shock?
A very, very interesting question. And the first one, the neurogenic shock, honestly, I will be very surprised if they don't. But I think we don't diagnose it well because we don't anticipate it. I came across this one patient a few years ago who developed this, what we always call it, looks like culture negative sepsis. So a kid who became unwell, we put them on antibiotic. We always call it culture negative sepsis. The kid who has got CRP low, no other evidence of sepsis, but hypotensive and looks horrible. I did the same thing. I called it culture negative sepsis, managed it like a septic shock. The kid did not survive, died. Parents agree for an autopsy. And the pathologist came back to me and said, well, I can solve your problem. This kid had severe brain stem damage from very severe high bilirubin kernicterus. And that brain stem damage, 100% will give you a complete vasoplegic phenotype. This is neurogenic shock. Till the time autopsy came back, we were calling it septic shock, right? So short answer is I suspect they do. We just don't know how to distinguish the two because they behave vasodilatorily. But the patients who develop vasodilatory shock physiology, normal CRP, blood culture negative, normal white cell count, we are just calling them presumed sepsis. I personally think many of them are not sepsis or NEC. I just don't know what they are. And numerous times we don't do an autopsy. So I think we underdiagnose this. Anaphylactic shock, I'm not sure. I'm not entirely sure whether our preterm babies have the immunity to actually mount a response of allergic nature. And that answer comes from blood transfusions. Our rate of blood transfusion reactions from an allergic point of view is next to nothing compared to adults. So I suspect they don't, but could be wrong.
The next question is from Neil Confett, my colleague next door here. And I think this is a brilliant question. Is there now enough evidence? Should we just stop using mean blood pressures?
And no, there is not enough evidence, right? Because the enough evidence will basically have to be showing that using this versus that outcome changed. We actually have no evidence to say using any blood pressure changes anything. We have association between blood pressure and outcomes. And blood pressure and surrogate markers of SVC flow, like you guys have done in Australia or we have done in LVO, we don't have. From a critical care perspective, mean blood pressure oftentimes is used as a surrogate for perfusion pressure because people think that mean blood pressure defines perfusion, even though the cardiac output is systolic blood pressure. But the cerebral perfusion or coronary perfusion is based on mean. I don't think there's enough evidence. Certainly in septic shock patient that I just showed the literature, the study we did, we found mean blood pressure to be only slightly inferior to systolic. Right? Our AUC was 0.80 for mean and 0.83 for systolic. So they both basically behave the same way in terms of accuracy. So I don't think there is enough evidence to stop using it. I do think there is enough evidence to stop using it in transitional hypertension as an isolated target, if that makes sense.
Well, you also explained that, by understanding different types of shock, adding systolic and diastolic and pulse pressure would give you a greater understanding or possibility of understanding. And I think that's my question would be related to that as well. You talked about these neurogenic and neurohormonal feedback mechanisms to the heart. And one of these statements when I was training was they said a newborn cannot create its stroke volume because it cannot increase its contractility. What do you think? Is that true? Or is the myth?
I honestly, I don't think so. I think it can. I personally find
recording stopped.
I personally find babies, particularly, and it's very hard to study that. It's very hard to produce data to be oscillate. But I think there's a transition from extreme preterm to a little bit less preterm, somewhere for 28 to 30 weeks, 32, 34 weeks, and then on. It almost feel like they behave differently at the beginning of the septic episode. Now, majority of our patients are going to be less than 28 weeks, so we are a little bit biased. But when we see babies early onset sepsis, 30, 31, 32 weeks, they are slightly different. I almost find them more often to be in cold shock physiology when they start off with than the extreme preterm. In terms of do they increase the contractility? Well, they certainly are hypercontractile. They have this ventricle touching each other and cardiac output not extremely high, but upper end of high, as you have shown before. And the question is it in response to vasodilatation or what their response to adrenergic surge overall, because you will get tachycardia from that also. It's very hard to tell. My experience so far is that they do behave. And the short-term blood pressure control, I see that multiple times. When you're looking for it, that patients who have vasodilatory, who have tachycardia, but it's compensatory, and they maintain their LVO just or cardiac output just in the right area, versus patients who have adrenergic surge, and you can be challenging to distinguish the two. A compensatory vasoconstriction versus a pathological catecholamine surge vasoconstriction can be tough because you don't know whether one is compensating or one is a problem itself. Because one needs Milleron, one doesn't. One the kid is doing well, but I do think they increase their contractility. Whether they do that at 22 weeks or not, I'm not sure.
Yeah, I would share that as well, that they certainly have the possibility, and the older you are, the more likely you can actually do it as increasing your stroke volume. Now, it was interesting in one of your studies, the blood pressure study from Zoo, and I really like that study, which showed, it's not about the number, it's about the drop in blood pressure, which should trigger you. That is our trigger for late onset sepsis, and we found the same here. Interestingly, you said there, actually, it was the change from baseline was independent from gestational age. Why do you think that is?
Yeah, it's very interesting because one of the reviewers, actually, maybe it was you, Kurt, I don't know, made us do an assessment of, because we were talking about absolute values, and obviously the absolute values will change with gestational age. So we did analyze that data, and when we looked at absolute values, with gestational age, there were clearly a responsiveness. But the delta, the percentage change or the actual drop, didn't add anything to gestational age. And no matter where you are born, what your baseline is, if you drop that much, it indicated that you had decompensated versus when you have no drop or very little drop. So I suspect it's more to do with the marker of severity of illness or the type of host than itself causing it. But it almost like, as you said, rightly said, we use it as a trigger. So, we measure it. So since that study in our unit, we have a policy, blood pressure measurement every 1 hour in the first 6 hours, every 2 hours in the next 6 hours, and every 3 hours in the next 6 hours compared to baseline. So we can trigger the patient who is showing signs that they are at high risk. By 18 hours, if BP remains rock solid, they're fine. They don't drop after that. So it actually helped us in just identifying those patients where we have to focus on energies more, and not miss them.
Yeah.
But I don't know. I don't think it's a cause and effect. I just think it's a trigger, as you rightly said.
It is past one. I'll do one quick question. You mentioned all the inotropes and the differences in there, but what's your thought about hydrocortisone?
You cannot talk about BP and hypotension without answering a question about hydrocortisone. It's very hard to have a thought about it, because there is just no data on effectiveness. So there is one study from Montreal where people looked at it and say, you know what, it does increase your LVO and increase your BP. And it does. Absolutely, it does. The data from adults is very clear. They have done an RCT in the vasodilatory, because adults, the reason I'm saying is that they also have vasodilatory shock as their primary physiology, which is similar to the preterm babies you deal with. They have completely demonstrated their primary outcome was normalization of BP and resolution of shock. Hydrocortisone early use resolve shock quicker in adult population for sure. Been proven. Does it increase BP in our population? I think it does. It clearly does. The question is that BP increase resulting in better outcomes? And whether we should be using it early means primary inotrope, very first, or failure of first drug. There is just nothing out there. So the study that we are doing in the CER that I shared, where we are collecting data on almost 450 patients, we are hoping to collect data. We are collecting hydrocortisone use as a part of it. They're not allowed to use it as primary because obviously we are comparing dopamine versus norepinephrine. But within that, we are collecting what is the second drug used and when it is used. And I know about 60% of units use hydrocort as second line. Others can't use it third line. So hopefully we'll shed some light whether it actually means something or not. Ideally, what we need really is either a trial or a similar study if we are doing early moment you have sepsis, hypertension, hydrocort versus hydrocort only after failing. That's what a study we need. Don't have it yet. I don't know what you guys do. Do you guys use it early or do you guys?
Same as everybody. First line, the sicker the baby, the earlier it started.
Yeah.
The less
And that's the
response
trouble.
to the
That's the
first
trouble
line.
with retrospective study.
Yeah.
Because we thought we'll look at it retrospectively, those babies who got it early versus a bit late. But those were early because they were horribly sick and clinicians were really worried. They all died. So
Yes.
that makes hydrocortisone look really bad.
Yeah.
But the selection bias prevents it.
All right, Amish. Look, thank you so much for talking for us, and thank you all for attending. A great attendance. Next week, we're going to talk with Professor Willem de Bode. He's going to talk about his PDA trial. I hope you're all back next week. Amish, thank you again. Have a good night, and we speak soon.
Thank you, everyone. Bye.